Good morning. My name is Alejandro Garcia. We're going to talk about a new topic. This is Encorafenib, Binimetinib, and Cetuximab in BRAF V600E mutated colorectal cancer. Colorectal cancer, also known as bowel cancer, is the development of cancer from the colon or rectum, parts of the large intestine. Some signs and symptoms may include blood in the stool, change in bowel movements, weight loss, and feeling tired all the time.
Hi, my name is Jeffrey Meyerhart. I'm a gastrointestinal medical oncologist at the Dana-Farber Cancer Institute in Boston, Massachusetts. I serve as the clinical director of the Gastrointestinal Cancer Center and the deputy clinical research officer of the Dana-Farber. Colon and rectal cancer is the fourth most common cancer diagnosed in the United States. It is probably also the most preventable cancer. We know that we can prevent colon cancer and improve mortality through screening. Those guidelines include checking stool for a blood that can't be seen. It includes doing a sigmoidoscopy or a full colonoscopy, which looks at your entire colon. The most effective screening is a colonoscopy. Most patients who are diagnosed with colon and rectal cancer don't have symptoms, but there are certain signs and symptoms that you should alert your primary care physician or other providers. Those would include bleeding in the stool, abdominal bloating, unexpected weight loss, and if you have blood tests and you're found to be anemic, those are reasons to screen for colon and rectal cancer. If you have these symptoms, it does not mean you have colon or rectal cancer, but it is a reason to alert your physician to be able to look further into your symptoms. Current guidelines suggest patients to start screening at age 50 unless they have certain risk factors. Those would include having a family history, particularly people who have younger family members who were diagnosed with colon cancer, or having a colon or rectal polyp, or having certain diseases like ulcerative colitis or Crohn's disease. The American Cancer Society recently came out with guidelines to suggest that screening should actually start at age 45. The risk is still very low in those under 50, but it is relatively increasing compared to where it was several decades ago.
BRAF mutation. The BRAF V600E mutation occurs in approximately 10% of patients with metastatic colorectal cancer, with recent estimates ranging from as low as 5% to as high as 21%.
We have recognized over the last couple of years that there is a subtype of colon cancer that has a BRAF V600E mutation, the same mutation that we see in melanoma and other cancers. It is a driving mutation for colorectal cancer, but in order to target it, we have to go at it in a different way. So we've spent the last few years figuring that out. Now, if you find a BRAF mutation in your patient, you already know that that's probably a bad prognostic sign. They tend to be more common on the right side of the colon cancer, but they can occur anywhere within the colon. There are more than one BRAF mutation, and so what we're really talking about here is just the V600E mutation. We don't really know what to do with the other BRAF mutations yet. So it's important to find it. You want to know it as a prognostic marker for your patient. But now you also need to know it because it is a therapeutic target. We're not quite where we were with, say, HER2 and breast cancer. We all remember that at the beginning, having a HER2 positive breast cancer was a bad thing until we figured out how to target it, right? And so with BRAF, we know it's a bad prognostic thing, but increasingly we are figuring out how to target it. Now, that doesn't mean you're rooting to have a BRAF mutation, but it is less of a bad thing now because we have ways to deal with it. If you have microsatellite unstable colon cancer, you have lots of genetic abnormalities, one of which is commonly this BRAF V600E mutation. There can also be BRCA mutations and other like that in MSI-high colon cancers. And for us in the colon cancer world, we have to figure out how to prioritize those mutations. Would an MSI-high colon cancer sort of push us more towards immunotherapy? Or would the BRAF mutated colon cancer push us more towards a targeted therapy approach? I think the consensus at the moment is in fact to try for the IO approach first. But it's sort of a wealth of riches when you have both of these targets in these patients.
The clinical manifestations. There are no symptoms in the majority of patients with early stage colon cancer, and these patients are diagnosed as a result of screening. Although the increasing uptake of CRC, colorectal cancer, screening has led to more cases being diagnosed at an asymptomatic stage. Most colorectal cancer are diagnosed after the onset of symptoms. The most common metastatic sites are the regional lymph nodes, liver, lungs, and peritoneum. The presence of right upper quadrant pain, abdominal distension, ileal satiety, supraclavicular adenopathy, periumbilical nodules usually signals advance of the metastatic disease. A combination of Encorafenib, Cetuximab, and Binimetinib result in significantly longer overall survival and a higher response rate than standard therapy in patients with metastatic colorectal cancer with BRAF V600E mutation. The doublet regimen of Encorafenib and Cetuximab also result in significantly longer overall survival and a higher objective response.
So for BRAF mutant, there is a big change, okay, because multiple studies showed that triple combination with a BRAF inhibitor in the center, with a MEK inhibitor now, before it was also tested with PI3 kinase inhibitors, and an EGF receptor inhibitors, in this case always Cetuximab, showed very promising results. In refractory patients, response rate over 30%, which is unheard for this disease. Now, recent data showed at World GI showed not only high response rate, but long progression-free and overall survival, which is the reason now the new concepts are that there is a trial being developed in first line. So now the interesting thing is this triple has no cytotoxics, only target agents, which again indicate when you are smart in identifying the molecular genetics of the tumor, you can successfully interfere and have dramatic clinical effect without a lot of toxicities.
The cons, headache, musculoskeletal pain, arthralgia, and myalgia occurred more frequently in doublet therapy group than the triplet therapy. The most common adverse events in the triplet therapy group were gastrointestinal-related and skin-related events, including diarrhea, nausea, vomiting, and acneiform dermatitis. Low hemoglobin level or anemia was a common laboratory abnormality.
The other interesting aspect of this study is when we take individually those agents, the Encorafenib, Binimetinib, and Cetuximab, their toxicities can be quite significant. When you put all the three together, the skin toxicities and other related toxicities seem to actually go down. They seem to abrogate each other's toxicities. So that's actually a relatively tolerable combination of agents. So I think that's going to transform how we care for our patients with BRAF V600E. Unfortunately, we didn't see the full results at ASCO, but they will be presented at both ESMO GI and ESMO, and I think hopefully somewhat at ASCO GI. So we'll see more of these results coming out.
The issue applied in Ecuador. According to the Solca National Register of Tumors, in 2014, there was 603 deaths of colorectal cancer in 2012. The incidence is rising up in men and women. The estimated rate of incidence is 11.8 cases per 100,000 population. Colorectal cancer is a common and lethal disease. Patients with metastatic colorectal cancer with BRAF V600E mutation have a poor prognosis with a median overall survival of 4 to 6 months after failure of initial therapy. A combination of Encorafenib, Cetuximab, and Binimetinib result in significantly longer overall survival and a higher response rate.
Management of patients with this particular subtype of colorectal cancer can be difficult because of how aggressive the cancer can be. Fortunate that we now have regimens that are responses for patients. The activity that we've seen in patients getting treated with Binimetinib, Encorafenib, Cetuximab regimen is encouraging. And I think we've seen there are patients that are respond, tumors respond, and have improvement in their symptoms. And I think importantly, increased durability their disease control, more so than we have seen previously. And that certainly provides hope that this is a regimen that can ultimately result in approval and availability for our patients. Obviously, we'll have to wait for the phase 3 study to read out, but we are encouraged that the FDA has recognized this regimen with the breakthrough designation last fall. So they'll rapidly reviewing the data as that becomes available. So we're managing patients with BRAF V600, in particular with Encorafenib, Binimetinib, Cetuximab regimen. It does require monitoring for eye toxicities. It can be with the Binimetinib a kind of transient blurred vision after dosing, but that usually resolves fairly rapidly within an hour or less of the dosing. But working with an ophthalmologist is sometimes needed if those symptoms become more problematic. Overall, the regimen is well tolerated. It is a regimen that really has very limited skin toxicities because of the blunted feedback pathways. So it's a rare scenario where the triplet is less toxic for the skin than individual agents. And that, I think, provides benefit for patients.
Thank you for your attention.